joining us on this episode of A Virtual View. This December, we're recognizing World AIDS Day, a global event that has been occurring for almost 40 years. I knew there was some telehealth application for AIDS and HIV prevention, as well as care management, but I wanted to learn more. To do that, I invited in two experts from IU Health Positive Link, Director Jill Stowers and Prevention Manager Emily Brinegar. These two had a wealth of knowledge and experience to share with me. Take a listen.
So I am Jill Stowers. I'm the director of IU Health Positive Link. We do HIV, Hep C, STI work really across the majority of the state of Indiana. I've been doing this work in the HIV field for about 25 years. 20 of them have been with this program, have seen just expansive growth as the science of the disease has changed, our access to different treatment modalities, different technologies has changed. It definitely has not been a boring ride throughout that. I have both my bachelor's and master's in social work, but have spent my whole career in the public health field.
Emily had a similar background and experience and a similar level of enthusiasm.
Jill and I look a lot alike on paper. I've also been in the field about 25 years and have been at Positive Link for 20 years. And have my master's and social work degrees, both from Indiana University.
The first thing I wanted was more information on IU Positive Link and what they did.
Yeah, so Positive Link started as an AIDS service organization right at the beginning of any type of federal funding. We were predated by our Community AIDS Action Group, which was a volunteer network. They still exist. They did not want to be like a federal grantee. And so they worked with, at that time was the Public Health Nursing Association in Bloomington, to start our program. Back in the early days, it was very much, two people doing a lot of hospice type work, making sure that people were dying with dignity. There weren't treatments, that type of thing. As the science kind of progressed, our services progressed to where now, and we also came under the hospital, lots of growth, all of the things. But at this point, we're one of the largest care sites in the state. Our focus is HIV and hepatitis. We do some STI work as well. We're very comprehensive in how we deliver services. And while we are a medical provider, we're part of IU Health. We are very much formed from a social work and public health framework of how we approach disease management, all of those types of issues that come up. So our medical care tends to be kind of the result of all of our social work and public health activities. So on our prevention team, Emily's team, we do free targeted HIV, Hep C, and STI testing. We're doing education and awareness. We're doing linkage to care, hepatitis management, pre-exposure prophylaxis, all of those types of things that we can do on the front end so that people don't end up in our care. If someone does test positive, we have a linkage to care program for newly diagnosed folks or for folks who have fallen out of care to reach out and help bring them back in, find out what their barriers to medical care were. We do medical case management, but a majority of non-medical case management. So really working with people with lived experience who are facing some kind of barrier. And in our situation, it doesn't matter what that is. It might not be medical in nature, but if it's preventing people from accessing care, then it's something that we're going to address. We have an extensive housing program. So sometimes it's just, somebody was sick for a few weeks or they were hospitalized for 2 weeks. And by the time they got back to work, they missed a check. We can just pay rent for a month, pay a utility bill, that April catch-up bill that everybody gets if you're on budget billing. We also then have some longer term subsidy programs for people that are going to be able to be self-sufficient, but it's going to take them a while. And we have some permanent housing that is for some of our clients that in order to maintain their adherence and maintain their health care, they need to have a permanent place to stay with supports in place. So we do that as well. Then with our clinical services team, we do primary care for people living with HIV. We do hepatitis C treatment. We're the PrEP prescriber for more than one region of the state. We do some street medic nursing. So we have some street outreach where we're bringing folks into care who would not otherwise make it in. I'm trying to think. We partner with all of the infectious disease providers kind of around the state, but we're really navigating Like, what is the client's experience and how are they getting to care? And virtual care over the last probably 6 years has been the area where the majority of our focus has been, and how we utilize that to bring people into care and to keep people in care who would otherwise fall out. So while Positive Link started in Bloomington, kind of serving the South Central region of the state, we actually provide services now in 60 counties of Indiana's 92. So we're a little bit of everywhere. We're not in the very far northwest, and we're not in the very, very far south, but kind of everywhere else. So we have offices in Lafayette, Muncie, two places in Indianapolis where we co-locate. We're in Terre Haute, Bloomington, Paoli, and Columbus. And then we have a satellite office where we collaborate up in the Fort Wayne area.
No, I love that you're addressing so many different like social drivers of health or determinants, whatever we're calling them these days. It's not just the medical care, it's all the other factors that impact it. I love that. But we moved more into talking about the virtual care aspect. So tell me more about that, like the successful models, the pilot programs, things that have worked in like the telehealth space to do this more in a digital health telehealth way.
So we were very trial and error as we moved through that. And we didn't set out initially to be like, let's have a robust telehealth model of care. That was not necessarily at the forefront of my mind, but it fills a lot of gaps, right? This was prior to COVID. So prior to COVID, it was definitely not, it was like this nebulous thing that was out there. Like, maybe this is something that could help our state be healthier or our nation be healthier, but nobody really knew how. For us, our kind of pathway into it was we had our clinic. Our clinic is in Bloomington. We have our actual medical provider, our nurse practitioner, is in Bloomington. She cannot be in all 60 of those counties. Like, she's amazing, but she cannot be in 60 counties. So this was pre-COVID. I would say like early 2018. We had our primary care and prep here in Bloomington, but we were also the only service provider in the Terre Haute region. And we were able to kind of either get people in medical care over there or get them over to Bloomington if they didn't want to seek services. A lot of people don't want their HIV care to be local for a lot of stigma reasons. So we could get them to Bloomington for that care. But prep was first of all, prep was a big thing at that time. Like, it was new. It was newly approved. It wasn't new. It was newly approved. It was newly talked about. And it was like, that is how we move forward in ending the epidemic. Is not, HIV services aren't on a continuum from like prevent at one end and medical care at the other end. Like, it's a circle. By providing medical care, we prevent the disease. But there were no PrEP prescribers, and there's still like not very many PrEP prescribers in the state of Indiana. So we had this whole population of people who were appropriate for PrEP. They lived over in Terre Haute, but our medical care was in Bloomington, and we did not have the funds to be driving people back and forth, and certainly not every 3 months. So we're like, how can we do this? And it was really just fumbling around to figure out like, how do we set up where like the billing works? Because everybody's like, yes, I'll provide care to whoever. Like, doctors and nurse practitioners want to provide care to people. It's the infrastructure behind that in our healthcare system in this country that makes it really difficult. So we just kind of fumbled through. We worked with a provider out there to like embed and collaborate. We worked with an infectious disease provider in Indianapolis. There was just a lot of trial and error, and we eventually got like an access point, the first of our virtual access points set up in our Terre Haute office so that people could access PrEP. That took like a year. So now we're in 2019. We just kind of rolled along. We're like, we're going to stabilize, get our stuff together. And then it was 2020. And then virtual care got very, very big, very, very quickly. But we were a little ahead of the game with it because we were doing it largely for like one particular service. We did like a little bit of infectious disease care virtually. We were pretty much doing PrEP. So when COVID hit and everybody suddenly had virtual care, there was suddenly a lot of TA resources on how to do it and how to do it better. So we were able to get like our infectious disease providers who were not like a Positive Link employee, but a collaborator in Indianapolis, also with IU Health, and set up like, how do we share a provider? right? Like we're a fairly small clinic. Like we're a part-time clinic. We're really small. We don't we don't have our own infectious disease care, but how can we set that up from an infrastructure standpoint on the back end so that our clients who are all over the state are able to access their infectious disease care? And then we kind of built PrEP into it. And then we started addressing Hep C more, like because there was suddenly treatment. And we were, we'd been doing Hep C work forever, but there wasn't a lot you could do other than tell people they had Hep C. And when it got bad enough, send them to a specialist. Well, that isn't the case anymore. And so how do we wrap in that Hep C care? And through it all, it was really trial and error, like setting up a model and trying it. And if it didn't work, not being like, oh, this doesn't work. And I think that is where a lot of people will give it a shot and they're like, well, this didn't work, so virtual care doesn't work. And we were like, virtual care will work. We have to adapt what our process is behind the scenes because it isn't the patient's responsibility to deal with our stuff. So at this point, we work with 4 different infectious disease offices. Again, we still have no infectious disease provider of our own. So we work with infectious disease offices in other parts of the state. We're able, because they have, nobody's like, I'll block 40 hours a week of my infectious disease care. Like there's a lot of infectious diseases out there. HIV is just one of them. But when you have providers across the state who can see people at different times, you end up with a fully comprehensive program that then we can get our clients into. Our primary care provider here, that is the Positive Links provider, she'll see our Hep C patients initially and then refer out for that specialty care if needed. But usually that can be done in a primary care setting. Large swaths of the state of Indiana still do not have PrEP prescribers. There's a lot of reasons for that. Like it is, from a capacity standpoint, in a state that doesn't have ready access to primary care in general, like we have a shortage of primary care. It's much better than it used to be, but that's still a fact. So having somebody that needs to be seen every 3 months who is otherwise healthy, like that's a huge utilization issue, especially when you look in rural areas that maybe only have one primary care provider. So if we can do that virtually from Bloomington, no matter where somebody lives, that's taking it's easing the load on the health system or the health provider in that local area. So at this point, we're pretty comprehensive, and we're actually moving into some street medicine through a HRSA grant that we're working out in Fayette County to do like a more targeted street intervention, street medicine for people living with HIV. We will, of course, wrap Hep C into that as well, because we will treat you for whatever we can. But so really kind of taking that next step, now that we have this increased access through virtual care, how can we then move that and say, like, let's target populations that we know are high risk and high barrier and make sure that they're getting the same access to care that other people have.
Moving on a little bit to look at things from a wider scope, I think the work that you've done is just incredible and so needed. But let's talk about World AIDS Day. So can you tell us a little bit about what that is and why it's like an important global event in the space, in the work that you do?
Sure, I can speak to that a little bit. So World AIDS Day is on December 1st. It was designated as World AIDS Day in 1998 by the World Health Organization. And each year there's a specific theme that's chosen and kind of utilized year round on more of an international stage, just to bring continued awareness to HIV and AIDS. The 2025 theme is Overcoming Disruption, Transforming the AIDS Response. Interesting thing about World AIDS Day is they don't actually announce the theme for the year until, I was able to find it yesterday, but I think I wasn't able to find it 2 weeks ago. So it's very, very close to December 1st when they announce it. But with this year's theme of Overcoming Disruption, Transforming the AIDS Response, just calling for continued political leadership and international cooperation and human rights-centered approaches to end AIDS by 2030. So I think, World AIDS Day is sort of celebrated, commemorated differently by different groups all around the world. More locally, our Community AIDS Action Group has always tried to participate in doing some sort of like ceremony of remembrance and also kind of call to action for moving forward in the new year. And we partner with various organizations to do different events. Like this year in particular, we're partnering with some student groups at IU Bloomington to do a number of things. We're going to be doing some testing. There'll be a panel on PrEP. There's actually also going to be a discussion about PEPFAR and what all has been going on with that. So, it's really just an annual time to bring attention to the cause on a more global scale, to talk about both local issues related to HIV while paying some time remembering folks that we've lost to HIV/AIDS throughout the years.
I think that's great. And I like that you mentioned it's down from like individual stuff to like encouraging individuals to get tested, to take ownership of their own health, that kind of thing, but also addressing the larger like systematic sort of ways that we can assist in this epidemic. So let's pivot back to talking about how telehealth is becoming more integrated with this type of care. So have you seen that telehealth has allowed us to overcome certain barriers around HIV prevention services? And I know we talked about this a little bit before, but particularly in like our rural and more underserved populations, is that something where you've seen like a lot of utility there?
For a number of reasons, there's not a lot of providers ready to prescribe PrEP. And do want to, make note that I do think a large part of that is the utilization issue, like she mentioned, with historically, we only had a couple of medications for PrEP, both oral interventions, pills that were taken daily. At least in the U.S., that's how it's approved. Around the world, there are some other ways that it's sometimes prescribed. But in the U.S., it's the oral interventions for PrEP are daily pills that people take. Along with that, there's historically been the recommendation that they have labs for STIs and HIV, as well as renal function, depending upon which medication that they're taking, every 3 months. And from a primary care standpoint, that's a lot of utilization for folks in primary care. So I think sometimes it really just comes down to a capacity issue. That said, I do think there is still a lot of stigma related to it. I think we talk more about integrating into primary care, looking at people holistically, but we know there are a lot of providers that talking about sexual health with their patients is just not something that they're comfortable doing, or talking about drug use with their patients, also not something that they're really comfortable doing. I think sometimes there's a lack of awareness from the providers that there's even could be an issue there, and they may be seeing people who would be good candidates for PrEP. And it is very provider, it really depends on the provider. I will say we are seeing more and more providers, I think, who are doing those screenings and having those conversations and might start folks on PrEP, but are often referring them to us, which is great because that means they know that we're able to do it and we're able to get folks connected to PrEP. And being able to do that via telehealth has been just so impactful, especially in the regions around the state, and where people may be in more rural areas, or also may just have very, very busy lives. And when it comes to PrEP, having our provider can meet with the patient virtually, put in a lab order, they can go to any lab to get those labs done. The provider sees them, gives them a call, everything's all good. Where do you want me to send your script? We also have case managers that can help navigate some of that for folks who may have issues with, is their insurance going to cover it? Or, figuring out what pharmacy that they can use. We have a lot of folks on PrEP who are younger, which is great. We haven't really talked much about this, but I think it's important to mention. And in this space, talking about PrEP too, is thinking about younger folks at risk, and all of our big offices are in college towns. So we have a large number of folks on PrEP who are, between 18 and 24 years old, like very traditional college age. Um, and a lot of times, folks go to college, they have never even scheduled their own doctor's appointment, let alone trying to figure out how to navigate what pharmacy they go to. And so we realized very early on that that was a big challenge with PrEP. And so that's one of the things that our PrEP navigators can really step in and help folks figure that stuff out while they're learning how to utilize the healthcare system. Yeah. And especially with that group, I mean, they are very technologically savvy. Like they can access a virtual appointment with great ease. So, for them, the fact that they can hop on a virtual appointment between classes is, can be a really, really big benefit. Additionally, then thinking about, folks in more rural areas, there may not be prescribers there, but sort of, similarly having access to virtual care. I mean, because it's really a simple, what needs to be done to screen somebody for PrEP readiness, and the labs that need to be done are really pretty simple and straightforward. And, there are very few co-occurring things that can impact PrEP. So, it's a great, virtual care is a really great option for PrEP. And then also important to note, and this is where we're kind of a new area that we're really still trying to navigate, is that historically medications have been pills that people take daily. There are now 2 injectables for PrEP. One is an injection that's given every 2 months. The other is an injection that's given every 6 months. That one is very, very new to the market. So one of the things that we're seeing, so we're still kind of trying to figure that out and what that looks like with virtual care, because that injection does have to be given by a provider. We've been doing some work figuring that out, and we're getting there. We're very, very close. Utilizing local infusion centers is a great way to be able to do that. There's also some options for home health to be able to provide that we're exploring now. So yeah, because I really think moving forward, those are just 2 big game changers when it comes to PrEP. I mean, there's a huge difference between getting an injection every 2 to 6 months and taking a pill every day. Not right for everybody, but definitely a great option for some people. So yeah, that's something that we're figuring out and working through right now.
I like how flexible you're being around like these different ways to deliver care, to deliver prevention, just trying everything and seeing what sticks, what works. I think that's a really smart way to utilize potentially limited resources.
So I think just kind of in response to your comment about like just trying things out. And it links back to World AIDS Day, actually. One of their kind of tenets and key messages this year is scaling innovation. And I think we're within IU Health and within Positive Link are just very big believers in like, you can't have every answer without trying it. And the best laid plans are going to need modified, and that does not mean failure. Having to pivot a little bit or having to refine is part of the process for us. And so as we've moved through and now moving into like, okay, what are we doing in the world of injectables? Because that's for treatment of HIV as well, not just for PrEP. Like, how do we do that? And it takes some wiggling and some negotiating with partners here and there to like, what if we tried this? let's give it a go for a couple months, see how it works out. And sometimes you have to scrap it, and not looking at that as failure. I think in terms of like barriers and challenges, labs are a barrier, and that's something that we are continually working to improve at. So we have more people trained as a phlebotomist than we had in the past, so that we can have phlebotomy available at each of our virtual access points. Getting to and from labs, getting your labs drawn on time, remembering to get your labs drawn. Sometimes is where that's at. I am a perfect virtual care candidate for the busy life situation. I was like, oh my God, if I could just like hop on for my 1 hour appointment versus needing a half hour of travel on either side of that. And now I'm blocking half of my afternoon. There are some very positive pieces of virtual care, which actually links back to like overcoming some of the barriers that I tend to see in the like more traditional healthcare space, is to like, we're going to do telehealth, but all of the supports around it are going to look the same as our traditional in-person office. And when you look at that World AIDS Day scaling innovation, it's like, look at it differently. Like, it can be just as successful of a treatment intervention, and a more successful treatment intervention for targeted populations. But you can't just do business as usual and think that like that is going to operate. And like, we have a load of front office, back office support, RCS, the people, like when you see your doctor, you're really seeing like 15 people most of the time. You just don't see them. And so what that looks like in a virtual care space, you really do need to innovatively look at like, what are the needs at each step, and not think that it's going to look just like your day-to-day in-person practice office looks. So we really, we modify what the tech looks like. We modify what the support looks like. How do we room a patient? What that looks like in person in our office looks different than it does when we're doing a virtual appointment. And so what staffing we have in order to do that, how the follow-up looks. Emily mentioned our navigators, for PrEP, for HIV, for Hep C, we have folks who are doing the follow-up afterwards and are communicating directly with the provider, no matter where they're at in the state. So we're getting real time, like we do it through kind of an internal chat that obviously is HIPAA protected. But like, how are we communicating? Because that provider might walk out of the exam room, look at their nurse and tell them we need such and such. Well, that still has to happen, but you might be 3.5 hours away from that person. So setting up the infrastructure to make it be successful is really important on the front end.
After hearing about all of the strides that virtual care was enabling in these communities, I wanted to hear more about the resources that they have available.
There are actually a lot of resources in this area, which is wonderful. They may not be there forever. Let me preface with that. But we do have the Midwest AIDS Training and Education Center. So Maytech is their main gig is working with providers. So while they do a lot of like HIV care type stuff, they're also working with primary care. They're also working around PrEP. Connecting with us, like I am happy whether people are IU Health providers or not. Like I've learned a lot, and I've learned a lot about what doesn't work, and I'm happy to share that with people. And it might work in other settings. It doesn't work in mine. But we can be a resource. Like I said, we're in most areas of the state. So whether it's a provider handoff piece, where they're going to start somebody on PrEP, but they can't, I live in a very small town. We have one doctor and one nurse practitioner for my county. They do not have time to see PrEP patients every 3 months, but they'll get them started and then have us follow up. So whether it's that, like, what is your capacity as an office? From a virtual care standpoint, I think it really is sitting down and looking at like, what are the needs of the patient population and what is the target population that you're wanting to do virtual care with. So for our program, it is a very defined population. In some ways, that is a luxury. My scope of service is very narrow compared to primary care, compared to a lot of specialties. But looking at like, when you look at your patient panel as a provider and say, I think these people would be the ones who would benefit from virtual care, well, then look at like, what are the supports that portion of your patient panel needs in order to make it successful? Like, do they have regular internet access? Do they know how to use it? Do you need to do an in-person and you set up the app? You have somebody in your office that helps them set up the app so that they can practice it once, like it could be a million things, but to just have that front thought of like, what would that look like from a development standpoint for a program, and how does it differ from our day to day? Because I think it is very discouraging for people. I get discouraged when I do something that I think is going to work and then it doesn't work. I don't think it's a failure, but I do think it's discouraging to me and I get frustrated with it. So the more that you can kind of go into it saying like, we want to figure out how to get to yes versus what are the reasons this doesn't work.
How can, just as some last thoughts, how can organizations like mine, like the UMTRC, how can we support you in this work? How can we make this easier for you?
Like, you have access to providers, right? You have access to providers who have an interest in this type of work. And that is magical, really. And so, gaining comfort with including sexual health as part of your body, like all of our body parts are part of our body. Like, let's talk about sexual health. Let's talk about substance use. And that, the majority of people have some kind of issue with one of those two things. And so let's make that more commonplace. And as providers have that discussion more often, then as those issues arise, they're more confident addressing it. So whether it's PrEP or whether, like, okay, we're going to actually screen folks for HIV and Hep C and do a full STI panel. And maybe that hasn't been consistent. I know in my personal healthcare journey, I've really only been offered that when I was pregnant, which was when I was at the least risk for anything, is when I was pregnant. So I think just having that like comprehensive view of the healthcare, and then knowing like, you don't have to do every single thing, where are the resources in the community? Because there are, obviously here within IU Health with Positive Link, but lots of providers across the state, there are several organizations that do HIV care. And so where is that link and where is that handoff, and just encouraging that is super helpful.
As our conversation started to wind down, I asked if there were any final thoughts among the team. And Emily had some things to say about how no one does this work alone.
We started out as a bunch of social workers. And so that's sort of our like looking at the big picture and like, where are those barriers and how can we step in to address that? And I think sometimes that isn't utilized in healthcare as much as it could or should be. So, really trying to figure out who are your partners that can help.
Thank you so much for listening to this episode of A Virtual View. And a special thank you to our guests, Jill Stowers and Emily Brinegar, for lending their expertise to this podcast. We hope to talk to you again soon.
Thank you for listening to A Virtual View. You can find more information about today's episode in the show notes below. If you would like to support our podcast, please rate and review us on your favorite podcast platform. Do you have any questions or topics you'd like us to discuss? If so, contact us at info@umtrc.org or through the form found in the show notes. Also, we'd like to give a special thanks to our editor, Tristan Yoder. Finally, a special thanks to the Health Resources and Service Administration, also known as HRSA. Our podcast series, A Virtual View, is sponsored in part by HRSA's Telehealth Resource Center program, which is under HRSA's Office of the Administrator and the Office for the Advancement of Telehealth. The content and conclusions of this podcast are those of the UMTRC and should not be construed as the official policy of or the position of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. Thanks for listening and have a great day.